So my brief is to speak on transcatheter mitral valve therapy as it stands in 2015. I'll focus most of my talk on the MitraClip because, as you've already heard, that is by far the device that we have the most experience with. We've heard some fantastic surgical talks today, what can be done, what's happening, what's just about to happen. We've just seen robotic mitral valve surgery, minimally invasive mitral surgery. So an obvious question is there a need for any transcatheter mitral valve therapy? Why not just medical treatment or surgery? And so if you look at this slide from the European Heart Survey done in 2007, they looked at a group of patients with symptomatic severe mitral regurgitation, and they found that only half of patients with symptoms and severe MR actually received active intervention for their mitral valve disease. So it would seem that there is a population of patients that remain undertreated with severe mitral regurgitation. The main risk that they didn't receive active treatment was that they were high risk for surgery. So advanced age, frail, they had high comorbidity, perhaps the etiology of the mitral regurgitation, so more functional mitral regurgitation, where surgery hasn't really been shown to be quite as good as it has been for degenerative MR. More importantly, if you look at what happens to the patient group that does not receive treatment for their mitral regurgitation once they develop symptoms, the outcome's not very good. This is a study from Cleveland Clinic put together last year, or published last year, of 6,000 patients with severe MR, of whom about 1,100 had developed symptoms. And you can see that for the ones who did not receive surgical correction of their MR, in the first year there was a 20% mortality, and up to 5 years, I'll see if I can get my mouse to work here, 50% mortality. And in those that survived, despite not receiving active treatment, a 90% readmission rate with heart failure after 5 years. So it's clear that there's a tremendous need in an ever-increasing group of patients, the high-risk elderly patients, for additional therapeutic strategies beyond just medical treatment and surgery. And I think the surgeons also would be the first to admit that that is the case. So today I'll focus, as I said, mainly on MitraClip because by far that is where we have the experience. And then towards the end of the talk, I'll maybe mention briefly some of the new techniques. There's lots of work going on in the transcatheter mitral valve area, annuloplasty, transcatheter mitral valve replacement, and so forth. And I'll focus predominantly on the devices that are now available in Australia so that you know a bit more about those. So just looking at MitraClip, it's truly become a global phenomenon. As of June last year, there were 355 centers, about 14,000 clips, 12,000 patients, most of those in some sort of registry or studies. The breakdown between functional and degenerative was roughly 70% functional and 30% degenerative. 99% of patients, or 96%, I can't read it from here, had a clip put in if that was the intention. And in the great majority, MR was reduced. If you look at the degree of MR reduction, MitraClip is not as good as surgery, probably. It's certainly not for degenerative MR. And we talk about reducing the MR from 3 or 4 plus to 2 plus or less. The reason that figure is important, a certain say, well, that's not really a great reduction, or that is not, you're leaving the patient with significant MR. But it has been shown that if the patient has 2 plus or less MR, then you get beneficial left ventricular remodeling, and that's very important for the outcome of the patient. Some of these slides you've seen before, and I apologize for that. So this is just a picture of the MitraClip device. It's a fairly complicated device. The device consists of 4 parts. Up here at the top is the clip delivery handle, which controls movement of the clip release, recapture if you want to reposition it. Then there's the steerable inner sleeve, which helps you steer the MitraClip down onto the mitral valve. Then the steerable here, the steerable guide, which the tip of which sits across the interatrial septum, and right down here, the clip itself. Over here is an enlarged image of the clip. You can see it consists of clip arms, which are about 8 millimeters long in the mobile part and 5 millimeters wide. And that's important when it comes to assessing what patients are suitable and how many clips you might be expected to use. About 40% of patients have 2 clips put in, 1% 3 or more clips. You have a thing called the grippers here, which have small hooks, I'll show you in the next image, which helps trap the leaflet tissue between the clip arms and the hooks. And then when the clip is closed, the leaflet tissue is trapped, and you approximate the anterior and posterior mitral leaflet and you're creating a double orifice valve. And in that process, you reduce the mitral regurgitation without making the patient have mitral stenosis. You do reduce the mitral valve area a bit when you put in these clips. They are 5 millimeters wide, and you do approximate the leaflets, but we test for this before we release the clip to make sure that the patient does not have significant mitral stenosis, and there are criteria we use to assess whether we've been successful or not and whether it's safe to release the clip. This shows you an enlarged image just of the very distal part of the device, the clip itself, and the tissue here, which is trapped between the grippers, which have got these hooks on them, and the clip arms. Once you're happy that you captured leaflet tissue from the posterior leaflet and the anterior leaflet, you lower the grippers, you trap the leaflet tissue, you close the clip, and then you assess whether you're okay to release the clip. I've got this video here too that Jürgen showed a bit and I'll just show it to you for those of you who may not have been through the MitraClip procedure before. It will give you a bit of an idea of the procedure itself. And I apologize that I'm not as savvy with my video clips as Jürgen, so I've got the whole video rather than just bits of it. Here's the device, and the procedure starts off with a right transfemoral access. You get up into the right atrium, you do a transeptal puncture, you place the, obviously that doesn't work, I'll just let it play. You place the steerable guide across the interatrial septum, you remove the inner sleeve, which you'll see here, and the wire, and then you have access to the left atrium. Through that steerable guide, you put the inner steerable sleeve, and it has the clip at the end of it. You can then maneuver the clip down towards the mitral valve. You want a posterior and a superior puncture. Posterior because, as you've heard from other speakers, the mitral valve lies posteriorly, and the posterior leaflet is a rather shallow leaflet with a big part of the circumference, but it's a shallow leaflet, so it's towards the posterior part of the left atrium. So to be over the line of coaptation, you need to have a posterior puncture. You need to have a superior puncture to ensure that you actually can fit all the device in above the valve. You then find the jet, you maneuver your clip down towards the jet. You ensure the trajectory is not medially, posteriorly, anterior, posteriorly, but in the long axis of the ventricle. You pass the clip through, you lower the grippers, and you capture the leaflets. And if you're happy, you let go. If you're not happy, then you can reposition it, reopen the clip and reposition it until the time that you think the mitral regurgitation has gone, you've got good leaflet insertion, and no significant mitral stenosis. Then, after that, you've got time to assess before you release the clip. You can also decide whether you want to put in a second clip. If you do that, obviously, you leave the steerable guide inside you. Okay, so where does the evidence come from? There's one randomized controlled trial, and they're few and far between when it comes to looking at surgical or interventional procedures. So we do rely somewhat on that, although the patient population studied in the randomized controlled trial, the Everest study, was a relatively standard risk patient group, not the type of patients we would treat now or suggest you treat now with MitraClip. It was a prospective randomized multicenter trial. It compared the efficacy and safety of MitraClip versus surgery in a group of mixed degenerative and functional mitral regurgitation patients. They were standard risk. The primary endpoint was freedom from death, reoperation for valve dysfunction, or 3 or 4 plus MR. So let me repeat again that if we get 2 plus MR, we'd like less, but 2 plus is generally accepted as a successful result from the clip. They were followed for 5 years, which is important if you want to know the long-term outcomes. And not all trials do that, but that's obviously very important. There's other information coming from high-risk registries, and the results are pretty much uniform across the number of studies published. There are about 280 patients in the Everest-2 randomized study, and they were randomized in a 2-to-1 fashion towards MitraClip or surgery. They were then followed for 5 years. As you can see down here at the bottom, the numbers after 5 years of follow-up are rather small, and you have to take that into account when you interpret the results. So when I say that there was no difference in survival, the study was not really geared to look at that. You can see here when you look at 1 year or 5 years, survival was the same when you compared the MitraClip to surgery, but remember the numbers are quite small, even though the different etiologies were mixed in this slide. If you look at it, breaking it down according to etiology, there's an important bit of information from this slide in that functional mitral regurgitation clearly does not do very well compared to degenerative MR, and you could also say that there was no major difference between surgery and MitraClip within those two groups of patients. There was one difference, and the primary endpoint was different between surgery and MitraClip in favor of surgery because the reoperation rate for 3 or 4 plus MR was more significant or more frequent in the MitraClip group. So that after 1 year, approximately 20% of patients needed a reoperation in the MitraClip group versus just 2% in the surgical group. After that, the curves are virtually parallel, no matter whether you look at mortality, reoperation, or 3 or 4 plus. And so it's true to say that in the first year there's a 20% failure rate of the MitraClip. I think that's no one's trying to hide that fact. Remember, we're looking at very high-risk patients that don't have any other options. And so an 80% success rate and then a durable result to 5 years after that is really not too bad in this group of patients. And of course, if you put a MitraClip in and they fail and you subsequently decide that the patient is operable, as has been mentioned by other speakers already, you can sometimes repair the valve still. If not, you replace it. So I think it's still a very good option for the right patient. You need to select your patients correctly. This slide just shows again that the reoperation rate was mainly in the degenerative group, and that within the functional group, there really was not much difference between surgery and MitraClip. It's interesting that when you look at the papers published by Alfieri, that it said that the Alfieri stitch on its own without an annuloplasty ring probably doesn't give you a good long-term result. Depends on what you mean by a long-term result. The 12-year follow-up was published and the results were reasonable. They are better with an annuloplasty ring for sure. In this study, and again, numbers are small, there was no difference up to 5 years in the reoperation rate between surgery and MitraClip. And yet with MitraClip, we're only doing the equivalent of an Alfieri stitch. This is how it was invented. It was to try and emulate the Alfieri stitch percutaneously. And so whether it's because, it was briefly mentioned before, a tissue bridge forms across the mitral bridge and it actually pulls the leaflets together as scar formation occurs, no one really knows, but that's one theoretical explanation. There were 2 things that were looked at in this study. MitraClip is safe. MitraClip is it effective? Is it safe? It was found to be safe. The interprocedural mortality in this group of patients was near 0. The complication rate was acceptably low. And the safety point, slightly unfairly, perhaps favored MitraClip because one of the endpoints in the safety point was blood transfusion. And of course, that's more common with surgery. If you take blood transfusion out, they were equally safe, virtually. It was slightly better in MitraClip, but not significantly different. The study found that MitraClip was effective. 75% had the clip deployed, an MR grade of 2 plus or less, what has been shown to lead to positive remodeling. And those are some of the other results there. If no recurrence at 12 months, you could expect a durable result. Saibal Kar, when he presented the 5-year follow-up results in the conclusion of the study at the EuroPCR meeting last year, and Saibal Kar is one of the very experienced interventional cardiologists that's been involved with MitraClip and left atrial appendage, bit of a character, said that for select patients, or concluded for select patients with significant MR of either degenerative or functional etiology, the MitraClip procedure is a therapeutic option with measurable clinical benefit and no late safety concerns. And in this group of patients, that's important. So we don't want to go and put MitraClips into young people with degenerative MR. They're for surgery each and every time. So just briefly, it is important to define what type of MR we're talking about. The outcomes are quite different. The treatment preference also are quite different. Degenerative MR, we've heard about fibroelastic deficiency in the elderly. They usually develop sudden MR from a ruptured something cord. Myxomatous degeneration is a more long-standing condition and much more complex and difficult to repair. Of the patients referred for MitraClip for the moment, about a third of them have degenerative MR, high risk. Surgical repair remains the treatment of choice for that condition, always, unless they have high-risk features. So that the recommendations at the moment are that MitraClip in degenerative MR could be considered in patients with symptomatic severe degenerative MR who fulfill the ECHO criteria, and I'll talk about those briefly, are judged inoperable or at high risk by a heart team. The heart team approach is very important. You get a surgeon involved who knows about MitraClip and mitral surgery. You get the procedural cardiologist, maybe a general cardiologist, anesthetist. Everyone's involved in making the decision, not just one person. And they must have a life expectancy of greater than 1 year. Otherwise, there's not much point in doing it. And in those patients, it's great. What makes a patient a high surgical risk? How do we decide that? One measure is the Euro score, another one is the STS score. There seems to be a sort of trend to moving towards the STS score. So an STS score of more than 8% is considered high risk. More than 12% is more extreme. How do you get a high STS score? High advanced age, lots of comorbidity, as you can see here in the left column, renal failure, previous bypass surgery, poor heart function, etc. There are some features that are not included in the STS score that will still make you high risk. Hostile chest from previous radiotherapy, the lemur crossing the sternum from previous surgery, and so forth, porcelain aorta. And so you will occasionally see patients with, and I think one example was shown earlier today, with a low STS score, but they're still high risk because of other features. So these are the kinds of assessments we do when we get patients referred for potential MitraClip. With respect to functional MR, it's a completely different condition. We divide it into ischemic or non-ischemic. Ischemic can be regional or global, depending on inferior, anterior, or both, infarction previously. It's really, the prognosis is in part, or perhaps completely, we don't know yet, determined by the degree of left ventricular dysfunction. We know that if you have functional mitral regurgitation on top of a poor ventricle, you do worse than if you have no MR. But we do not know whether targeting the mitral regurgitation specifically with a clip or repair or replacement actually improves survival. Has never been looked at in a randomized study, neither for surgery yet nor for MitraClip. So there are 2 ongoing studies with MitraClip now looking at optimal medical treatment versus optimal medical treatment plus MitraClip in patients with functional MR. In those studies, we are not distinguishing between ischemic and other types of functional MR, but at least it's all what we would call functional MR. They will report in the next couple of years and we'll know more then. To my knowledge, there are no surgical studies that have randomized between medical therapy and any form of surgery for functional MR. About 2/3 of patients are currently referred for MitraClip have functional MR. The mechanism you talked about, it's an imbalance between tethering forces and closing forces, and the MitraClip addresses that to a certain extent. It's important to understand that functional MR is a dynamic condition. You can have functional MR, which is severe, and you come in with decompensated heart failure. You treat the patient with medical treatment, heart failure gets better, and the MR reduces significantly in severity to the point where you think, I don't need to treat this. And I think that may very well be true the first or the second admission, but the patients do tend to come back, and eventually, overall, there will be a deterioration. And I think at some point you have to decide, is this person suitable for a clip, for a surgical repair, before they go too far down to sort of irreversible heart failure. From the randomized studies, from subgroup analyses, it was found that the elderly patients and those with the functional MR did particularly well with MitraClip. This study from Hansen from 2010 showed that if you let the patients go too long, the outcome is not quite as good, even if you clip them. Both patients with functional class 3 and 4 benefited from MitraClip, but you can see here that the dotted line on top was class 3, and the 1-year outcome was excellent, whereas if you had class 4 with breathlessness, at rest, in bed, unable to be sent home from hospital, your mortality is still pretty high, even after MitraClip. It might have been even higher without it, but we don't know that for sure. Whether you're treating patients early in the natural history and not altering it at all with MitraClip, or whether you're treating them early in the natural history and altering the natural history of heart failure and the mitral regurgitation, we will only know once the COAPT and ReShape studies, those randomized control studies, are out in the next few years. So far, it's an educated guess. What about surgery for functional MR? The operative mortality is higher. There's no survival benefit. The results are probably less durable, as I think you've heard said today. It is a bit more invasive. The results are similar to MitraClip in that you get symptomatic improvement and you get left ventricular remodeling, and that's a good thing, we think. But we do not know about survival yet. Do we know what type of surgery to prefer? You've seen this study presented already. For degenerative MR, it's a no-brainer. You repair, at least most of the patients. For functional MR, it's not quite as straightforward. Perhaps it was thought that repair was less invasive and more beneficial for the ventricle. This study by Ackers, published in the New England Journal last year, a randomized prospective study of some 250 patients or so, showed that at the end of 1 year, comparing replacement versus repair, there was not much difference. And this was sort of replacement preserving the subvalvular mitral apparatus to perhaps help reduce the degree of left ventricular dysfunction that might otherwise occur. What about age and STS score? We talk about excellent surgical outcomes, but I think once you move into the patients in their 80s, then clearly comorbidity, frailty, and other things will influence the outcome. And so if you're that old, the mortality and morbidity goes up significantly. From the latest STS surgical database, if you look at degenerative MR and functional MR in patients who have STS scores of over 12%, the mortality at 30 days is between 17 and 22%. It's about 7 to 9% in those with an STS score of 8%. So the STS score, age, and other factors will help stratify patients into one or other treatment. There are some steps you need to think about before, especially for functional MR, before you go ahead and say this person needs a clip. You want to make sure that they don't need to be revascularized, just like you would if you sent them for surgery. You want to make sure that they are on optimal medical therapy. Beta blockers have been shown to improve LV function, and by doing that, they improve closing forces, and by doing that, they reduce MR. So beta blockers reduce MR. So you must have them on appropriate medical treatment. You must offer them cardiac resynchronization treatment if they have bundle branch block, impaired left ventricular function, because that improves survival, it improves LV remodeling, ejection fraction, and it reduces mitral regurgitation, functional mitral regurgitation. So that is a treatment that must be tried before MitraClip, and indeed before surgery, if it's appropriate. Finally, rhythm and rate control, obviously important. AF can make you short of breath as well, so even if you have a repair one way or the other, it's worthwhile attending to that. So for functional MR, it's a bit more complicated, but MitraClip may be considered in patients with symptomatic severe functional MR despite optimal medical treatment, in those where CRT and rhythm control, revascularization has been tried and who fulfill the ECHO criteria, have been approved by the multidisciplinary team and who have a life expectancy of more than 1 year. So a fair few things to take into account. I'm not so sure about whether surgery is indicated, not very commonly anyway, just for functional MR. I think if you have tricuspid regurgitation that needs to be dealt with, sure, then it's surgery because we can't deal with that through the MitraClip. If you have coronary artery bypass grafting that has to be done and it's not suitable for percutaneous intervention, then surgical repair is okay. Surgical repair for severe MR, probably, definitely. Moderate MR, I think the jury is out as to whether it actually is helpful to repair those valves, even if you have to do surgery in the first place. And now that there are other strategies becoming available, perhaps you don't need to anymore. This is something we can discuss after. So in summary, just so that putting it all together, the MitraClip in functional or degenerative MR improves symptoms, mitral regurgitation grade in the great majority, quality of life, it reduces readmissions with heart failure, it causes positive left ventricular, and more recently it's been shown right ventricular remodeling if we achieve less than 2+ MR. There's one Canadian study, this was talked about earlier, that shows that it's cost effective, I think to an ICER about $24,000. Depends a bit on whether you compare MitraClip to medical treatment or whether you compare it to surgery. And then what about survival? There's some preliminary indirect data available, prone to bias because it's not randomized, it's not prospective, it's retrospective, to suggest from the high-risk Everest study that perhaps MitraClip improves survival. This was 2 cohorts of patients. They were both suitable for MitraClip. One ended up having the MitraClip, the other one did not, and there was a difference in mortality after 1 year. But clearly, selection bias could creep into a study like that. There was another study published last year in JACC Intervention that showed that surgery as well as MitraClip may have a survival benefit. But again, selection bias probably could influence these results. These are the studies we're waiting for, and Michael maybe and Jürgen may be able to inform me as to whether there are any surgical studies underway, any randomized control studies underway. The COAPT and ReShape studies will compare optimal medical treatment to optimal medical treatment plus MitraClip. This will tell us whether the MitraClip has whether treating the mitral regurgitation independent of the left ventricular function is actually helpful, not just for symptoms, which I think we know it is, but for survival improvement as well. And they will report in the next few years. Very briefly, just some of the echo criteria. There are general echo criteria that you might want to look at, and then there are leaflet-specific criteria for degenerative and functional MR. The general criteria for MitraClip, we like A2P2 pathology. Why is that? Because there aren't many chordae in the way in the center of the valve, so that's why that was chosen. We can do medial and lateral jets as well. We like a mitral valve area more than 4 square centimeters because we do reduce the mitral valve area once the clip is applied, especially if you think in advance you might need more than 1 clip, and that happens in 40% of patients. We like a mean gradient less than 3, and obviously need 3 or 4+ MR. The posterior leaflet needs to be 8 to 10 millimeters in length. You want to avoid very thick leaflets like Barlow's leaflets with more than 5 millimeters in thickness, leaflet calcification in the grasping zone, and a cleft. I've heard talk about clefts today. I was of the opinion that clefts were a congenital thing and quite rare, but obviously you can have acquired clefts somehow if they extend more than 50% of the thickness or the depth of the leaflet, or are they just exaggerated indentations? I'd be interested on the surgical comments on that. These are some of the specific leaflet criteria, and these ones are both important for degenerative MR. We want the flail gap, that is the gap between the flail leaflet tip and the non-flail leaflet tip, to be less than 10 millimeters, unless it's a very focal prolapse of flail, in which case we can accept the greater gap. The flail width, which is often looked at in the 3D en face view, should be less than 15 millimeters. If it's wider, you require more clips. You've got to make sure that the area is capable of taking more than 1 clip. For functional MR, there's really only one criteria, and this is the one on the left here. You must have some degree of coaptation. preferably about 2 millimeters. Otherwise, it becomes harder to put the clips on. The coaptation depth is an Everest 2 criterion. It's not really thought to be that important anymore. Other contraindications, active endocarditis, leaflet perforation, doesn't get better with MitraClip. Rheumatic heart disease, mitral stenosis, mean gradient more than 5, it's too much. MitraClip is not suitable for such a patient. Mitral cliffs in the grasping zone in particular, and probably in general, not suitable. Prior leaflet surgery is interesting. If you've had a bioprosthetic valve replacement, obviously not. Mechanical valve, obviously not. Posterior leaflet repair, not, usually because the mitral valve area is too small. And a ring, an annuloplasty ring, it is potential to repair those with MitraClip if they fail subsequently, as long as the area is sufficient and as long as the annuloplasty ring does not degrade the image quality. The MitraClip procedure is 90% guided by toe, and if you can't see what you're doing, just like very clever Michael Stevens said, if you can see it, you can stitch it. Well, if you can't see it, then you shouldn't attempt it, obviously. And so it's important that you can do that. So anything in there that shouldn't be there, or that wasn't there in the first place, could interfere with the image quality. There are some uncertain sort of gray areas. You've got to make sure that the patient will benefit from the MitraClip. So if they're very breathless and you think that the breathlessness could be caused by something else besides just the mitral regurgitation, ask yourself the question, is it wise to perform a MitraClip on this patient? If you see the interatrial septum bulge from right to left, usually that is not all caused by MitraClip, but by the mitral regurgitation. There's got to be some other pathology, and you've got to take that into account in your assessment of the patient. And so this is just a summary slide. You've got patients with severe MI, you assess them. If you think they're high risk based on STS score, which you can go and work out online, it's very easy. Or other features, if they have fulfill all the inclusion and exclusion criteria. You do your transthoracic echo. You've seen lots of examples of that today. You grade the MR using at least 3 different criteria, preferably qualitative, semi-quantitative, and quantitative measures in your assessment to make sure that they really have 3 or 4 plus MR. You assess the mechanism as much as possible on 2D. You look at the number of jets. You look at the inclusion-exclusion criteria, the general ones, the specific ones, and then you look at the rest of the heart, left ventricular function, RV function, pulmonary pressures, the septum, because we have to cross that to do the MitraClip. If they've got severe TR, they're not suitable for MitraClip. They should have surgical repair. You look for other causes of dyspnea and you exclude those if you think that they won't benefit: end-stage lung disease, severe pulmonary hypertension due to other causes. Your checklist for functional should include optimal medical therapy, revascularization, CRT, rhythm rate control. You go to a toe, you confirm the severity, although the toe is often not so good to look at the severity because the patients have been fasting all day. They have an anesthetic on board. They're a bit underfilled, so filling state obviously determines how bad the MR looks. But you definitely look at the mechanism on the toe to try and establish what the mechanism of the MR is to see if it's suitable for MitraClip or not. The location and number, 2D and 3D, as you heard already by Jason Kaplan and Lisa Thomas. And then you go to the multidisciplinary team to decide if it's on or not for a final check of their functional status and surgical risk. These are just a few snapshots. Flail width up here, 2 examples. On the left, 10 millimeters, that qualifies. On the right, 25 millimeters. Too many clips probably required to fix that one. You'll end up causing significant mitral stenosis. On the right here, mitral valve area of 5.8, that's great. This one here, 2.1, too small, not for MitraClip. You'll end up causing very severe mitral stenosis in that patient. Over here, the flail gap, 8 millimeters, that qualifies for a MitraClip. 12, borderline. We can accept 12 only if the flail width is quite small. Depth over here, coaptation depth, not looked at so more. As I said, coaptation length, the length of the overlapping coaptation zone is the important bit. Couple of examples of primary and secondary. primary or degenerative MR with a flail P2. So in the LVOT view or long axis view, you're looking at A2 and P2, and you can see an anterior jet, and you can see in the 3D toe a beautiful P2 prolapse. Down here, you can, in secondary MR, you can tell that the ventricle may be a bit dilated. There's tethering of the leaflets. Probably there's asymmetric tethering in this case, with the posterior leaflet more tethered than the anterior leaflet. The anterior leaflet underrides the posterior leaflet, and you get a posteriorly directed jet. And on the 3D toe, you might see a gap in the coaptation where the jet is placed. On the bicommissural view here, or the intercommissural view here, it looks like it's more towards the medial side. That's on the left side of the bicommissural view. It's on the right side of the surgeon's view of the 3D en face. A couple of quick ones. Complex Barlow's disease, probably not for MitraClip. Cleft in the posterior leaflet. It's got to be very rare if we're just talking about congenital clefts in the posterior leaflet, but they're definitely not for MitraClip. Here's a flail cord in A1 segment, which you can see in the 3D toe. That might be suitable. It's not the typical case. It's a higher risk of interfering with the chordae, but it's possible. Stenosis, not on. Functional MR with lack of coaptation, that's quite possibly suitable for MitraClip. And here you can see two examples of flail segments. This one is A2 with a flail cord, P2 with a flail cord, and over here complex Barlow's disease affecting A2, A3, P3. Again, probably not suitable. Perforation can't be fixed by MitraClip, so again you see that it's either medical treatment or repair or replacement, depending on what stages the patient's at. And I might go, rather than showing you any more pictures, I might just go to show this patient here. This is a patient that was treated recently, an 87-year-old lady with recurrent pulmonary edema who let's see here, who has severe aortic stenosis, and also you can appreciate she has a flail P2. This is the LVOT view, and a bit of flail cord there. The flail gap is just at the upper range, but we think we can treat that with a transcatheter aortic valve. Then reassess the mitral regurgitation, which sometimes gets better. The flail segment, it's unlikely to. And then MitraClip if required. And I'll go through my letter. I'll just briefly talk about some of the transcatheter other techniques that are becoming available in Sydney in particular, but around Australia too. They fall into two groups, annuloplasty and mitral valve replacement. Annuloplasty can be considered indirect if it's performed through the coronary sinus device, which squeezes the annulus, bringing the leaflets together, or direct if it's a direct annuloplasty ring placed either on the side or the atrial side. Mitral valve replacement, there are various ones we look at. Valve in ring, which was talked about earlier. That's becoming well established and might influence whether you get a bioprosthetic mitral valve or a mechanical valve now. We can talk about that more later on. Using TAVI valves for native mitral stenosis or native valves with extensive mitral annular calcification has been done now, either transapically or transeptally. Transeptally either from the femoral or jugular approach. And finally, which is what I'll talk a little bit about, is dedicated mitral valve, transcatheter mitral valves for native mitral regurgitation, either functional or degenerative etiology. So indirect angioplasty, there's been a couple of devices. Edwards had a device called the Monarch device, which was withdrawn due to coronary occlusion. The Carillon device has gone through a phase of a number of studies, and we're about to start participation, as I think is Prince Alfred, using that device. Direct annuloplasty devices are more complex. Here you see a picture of the coronary sinus. And if you place the device in here, you can see that this device runs around the posterior and lateral part of the mitral valve, and so it will help squeeze this section together, causing approximation of the leaflets, reducing the size of the annulus, particularly good in functional MR. I'll skip the Monarch device because it's no longer there. Early studies, preliminary studies, the Amadeus, Titan 1, Titan 2, using first generation, second generation devices have shown similar findings to MitraClip or surgical annuloplasty rings, alveoli repair with left ventricular reverse remodeling, improved MR grade, New York Heart Class, 6-minute walk test, quality of life, etc. No survival data. There's a couple of hundred patients that have been looked at. CE approval was approved for the latest iteration of the device, the third generation, which is now being tested in the reduced study. It's put in through the transjugular approach through a 9 French sheath. It takes about an hour. It's done under local anesthetic or conscious sedation with some guidance. Pre-imaging is important, CT, echo. It's up until now, it's only been possible to put the device in about 70% of patients that you've judged were probably appropriate for the device. The reason for that is not being able to find the coronary sinus in a small percentage of patients. You can put it in, see the degree of mitral regurgitation you get, and then decide whether you leave it or not. You can recapture it if you're not happy with the result. And if you get no reduction in MR, you take it out. You don't leave it in there. And so that's the other reason for failure. And finally, it depends on studies you look at, between 20 and 70% of patients, the circumflex coronary artery runs between the mitral annulus and the coronary sinus. So if you're squeezing the annulus by pushing on the coronary sinus from the outside, you might compress the circumflex coronary artery. And so you do an angiogram before you release the device to ensure that you're not doing that. And that is also a reason for not delivering the device in a percentage of patients. Finally, you have to ask the question whether delivering this device in the coronary sinus will actually help the mitral regurgitation. It has been shown to do so, but in patients with dilated hearts, the coronary sinus tends to migrate superior and it lies further away from the mitral annulus. And for that reason, the device, you would think, should become less effective in reducing the MR. Having said that, it seems to work in 2/3 of patients. Direct annuloplasty, just a very quick word. It's really very early days, preclinical stages, first in human trials. The GDS device is being used in Australia. The principal investigator site is Monash. St. Vincent's in Sydney are thinking about starting this. David Muller's thinking about starting this. This is a device which is, it's an annuloplasty ring applied from the ventricular. It's a transventricular device. So you go through the aortic valve, retrograde into the ventricle, you apply the device from the ventricular side, and so you've got to avoid the chordae. To me, that sounds like a difficult process, but the surgeons might think that's not so difficult. I don't know the anatomy well enough. It seems to be a difficult concept for me to get around. The Valtech Cardioband device, on the other hand, is delivered via a transeptal approach from the left atrium, and you anchor it around the annulus of the mitral valve from the left atrial side, and you pull on some strings to bring it all together. That's how all the devices work. There's some early data from about 20 patients from Milan, and there's a CE trial, I think, ongoing at the moment. Sounds very interesting, very early days. Mitral valve and valve and ring, I won't talk about that. That's fairly straightforward. Transcatheter aortic valves to be used in the mitral valve position for heavy mitral annular calcification, circumferential mitral annular calcification, or mitral stenosis. There's about 10 cases in the world literature at the moment. They're either done transapically or via the transeptal approach. Very elegant. I saw one at the EuroPCR meeting last year. Took 20 or 30 minutes to put a valve in. There was not much paravalvularly. Amazing procedure. And just finally, these are valves that are designed or dedicated for the mitral valve, for the nature mitral valve. that's leaking. So there are now a number of valves that are made available by Edwards, by other smaller companies, to treat native mitral valve regurgitation. The cardiac valve was tried by a guy called Søndergaard from Denmark. It's about 3 cases just published this year. I don't know where it's heading at the moment. I think it's probably been put on hold. A couple of the patients died early. The Tiara valve has been tested in Canada by Hansen from Vancouver. And they're getting very good results, I think, and they published about 5 or 10 of their first cases. There's not many more patients that have been done to date. The Fortis valve has been tried by Martin Thomas and Vinny Bapat in St. Thomas's in London, and they've got some early preliminary first-in-human trials. And the Tendyne valve, finally, is the one that David Muller is using in Sydney. You might have read in the Herald the other day about their second case. First 2 cases have gone well. It's a device that's delivered from the transapical approach through the mitral valve into the left atrium, where it is released. It has a rim that is the anchor from the left atrial side. It then has a pledget that goes to the apex of the heart with a little disc on the outside, which is tightened, which is a ventricular anchor, and then it's got a self-expanding mid-portion, which hopefully prevents paravalvular leaks. It's relatively straightforward to put in. It does require a large gauge cannula, I think 32 French or something like that, at least for the first iteration of the device. I don't know about the latest one. It takes about an hour to put in once the transapical approach has been established. There are some special considerations for these valves that don't apply to, say, the aortic valve. And one of them is that the ventricular pressure, the gradient between the ventricle and the left atrium is huge compared to, say, ventricle and aorta. And for that reason, if the device is not properly anchored, it will eject into the left atrium. So the ventricular anchor is a really important feature of these new valves. The other things are the D-shaped annulus, the saddle-shaped plane of the mitral valve, the fact that you don't want paravalvular leaks because they tend to cause problems, much more so than aortic paravalvular leaks, thrombosis, the fact that when the ventricle remodels and reduces in size, what happens to this device that doesn't change much? Does the tether develop a slack? There are lots of considerations, and it's a difficult area that's being looked at the moment. So I'll finish here. I've probably talked more than enough now, and we can go on to the questions.